Well, I did my fellowship training a long time ago, 20 years ago in Dallas with doctors John Lynn, Ron Feldman, and Rich Starita at Glaucoma Associates of Texas. And it was at about that time that viscocanalostomy was kind of coming into vogue. And I sat in on a lot of what I thought were very difficult surgical workshops on that. And I had also participated in cases where my senior mentor would spend sometimes hours trying to cannulate Schlemm's canal of infants with blunted proline suture for trabeculotomy. So those experiences really left me with the impression that Schlemm's was very difficult to access and was probably best left alone, at least by me. So during my 20 years of private practice in East Texas, a small community with a really large draw area where you can relate that we as physicians really live and die by word of mouth. I avoided that type of procedure. I'm in a single physician private practice with a really cost-conscious ASC. And I've really become a veteran of penetrating procedures. My personal go-to procedure has been trabeculectomy, most recently with the Express Mini Shunt, and I've had a real high success rate with that, but as you've heard and as everyone in this room knows, we can all relate to the fact that even the best trab surgeons face that long-term morbidity associated with extraocular shunting of aqueous and the bleb-dependent procedures. So I resolved to look again into the validity of canaloplasty, which has really come a long way from viscocanalostomy, and then to try to overcome my own obstacles to adopting it. And I'll tell you now that my perception of the obstacles was really different from reality. First, speaking to validity of this procedure, there's no dispute over validity of avoidance of long-term bleb dependence and hypotony. All trab surgeons acknowledge the unpredictability of and the morbidity associated with bleb morphology and the problems that that creates for our patients. And reestablishment of intrascleral physiologic aqueous flow really should be our holy grail. And canaloplasty, in accomplishing this, really effectively avoids not only bleb morphology, but serious long-term hypotony, the all too familiar related pathologies, the vicious cycle of choroidal effusion, and related maculopathy and suprachoroidal or expulsive hemorrhage. And not only does canaloplasty avoid all of that, it really does lower IOP very nearly as effectively as the penetrating procedures. This is Dr. Lewis's data comparing IOP and the need for IOP lowering meds at 3 years with canaloplasty without and with phaco versus trab or tube. And you can see that IOP really is lowered by canaloplasty very nearly as effectively as the penetrating procedures. So for me, yes, it's a very valid long-term bleb and hypotony avoiding procedure that lowers pressure physiologically. But regardless of that, as I mentioned, for me personally, there were obstacles to my adopting the procedure in my clinical practice, including, as you've heard, intimidation over the really deep dissection required to reach and manipulate unfamiliar anatomy, especially without a surgical mentor on site, and with fear of the learning curve and risk to the patient, as well as anticipation of inappropriately long surgical times and unaffordable cost. But again, in retrospect, my perception of those obstacles was different from reality. Once I made the decision to address this, for me first, a very good understanding of the dissection was really important and allowed me to ease into a successful learning curve. That superficial flap has to be dissected, as you've heard, well into clear cornea to allow an adequate size of the Descemet's window after the deep flap is excised. Also, the deep flap must be dissected very deeply, just superficial to choroid, mainly to most easily access the canal on the first pass and not have to redissect multiple times to reach the canal, but also to effect a real thin Decime's window, which allows better flow into the lake and a lower pressure. And of course, practice makes perfect. We all know this. Repetition of the dissection, for me, was absolutely key in smoothing the learning curve. And my learning curve is also just a little over 6 months long and 50 cases, a little over 50 cases now. Also, the idea that perforation, we need to discuss this, is a deal breaker is, I think, absolutely wrong. I have not converted to trab. All the trainers know this with me well. I'm a perforator, and I don't convert to trab. I've converted probably 2 out of those 50 to trab. If the perforation is small and you still have an adequate Decime's window to tension that suture over, you absolutely don't have to convert to trab. And in my limited experience, and the trainers assure me of this, perforation is not at all a deal breaker. These cases are very successful. And it's already been said that glaucoma surgeons are really the best equipped to be masters of this procedure. Glaucoma surgeons who have not gotten into this are really missing an opportunity. We have experience with flap dissection that really prepares us for a smooth and successful learning curve with this. But again, even as a 20-year veteran glaucoma surgeon, I had great hesitation due also to these obstacles, but I made the decision on the basis of validity of the procedure to overcome my obstacles and commit to that learning curve. And really, after understanding the dissection, the first step for me was correctly identifying candidates for the procedure. The second step, and possibly one of the more important steps, was enlisting this excellent team of iScience surgical trainers. And I know that Shannon is here tonight. She is one of these superb trainers. It's a large team of people who will come into the OR and help you make this transition. It's absolutely essential to enlist those people. And the final step, as you've also heard, was a very strong commitment to repetitive consecutive cases in order to be successful. Good candidates for the procedure, of course, have open angles so that you don't induce PAS with the suture tensioning of the canal. Prior ALT may or may not be a relative contraindication to the procedure. There may be a higher incidence of not being able to pass the catheter or catheter or suture prolapse through the TM into the chamber in these cases, maybe through that more brittle trabecular meshwork. And of course, the canal needs to be intact to successfully cannulate and suture tension it. So trabectome would be contraindicated in patients who have had trabectome. And patients with critically advanced glaucoma, we know, may fare better with a penetrating procedure for most aggressive pressure control, but consider the all too common scenario of the black patient with advanced glaucoma who has widely open angles and extremely high baseline pressures, and the really dismal failure rate of penetrating procedures in this particular patient. And I'd submit to you that this patient may be a very good candidate for canaloplasty as an initial or early procedure, especially if that patient hasn't had a long history of treatment with IOP meds and surgeries, which we know bypass the network and can atrophy that available network for canaloplasty. Well, after correctly identifying good candidates, establishment of that surgical mentoring for me was essential. And this team is so good. They're a large rotating team. They'll come into your operating room on consecutive weeks and give you very professional, well-communicated, detailed instruction for both you and your staff. And it really makes for an enjoyable, successful learning curve. Also, the point about booking repetitive consecutive cases on the same surgical days and on consecutive weeks cannot be overemphasized. This really hastened my learning curve, and my preference was and still is to place canaloplasties at the end of the surgical day when I can slow down and emotionally relax a little more and enjoy that dissection rather than be distracted by the pressure of being extremely efficient in the OR. And here's what I experienced and I want to stress very early postoperatively, usually day 1, compared with Dr. Lewis's larger sample in the first column of the canaloplasty plus minus phaco group. My first 25 cases are the next column in that group, and as my cohort increased to 50 over 6 months in the third column, you can see that my incidence of hypotony day 1 is significant because we do perforate when we're in our learning curve. Hyphema actually does occur fairly commonly, but again, it's short-term, short-lived, and seems to be very low risk. I had a patient, one patient with choroidal effusion, and this was a young guy, very high myope. Had a brief period of hypotony, but it was enough to give him a choroidal effusion, which thankfully very quickly resolved. And I've had a case of, on one patient, 2 small focal decimase detachments. And in retrospect, that was, we had a brand new scrub tech on that case who was over-delivering Helon on withdrawal of the catheter. And every time we said click, she was click, click, clicking. And so we got 2 little focal hemorrhagic decimase detachments, which were not in the visual axis and have resolved spontaneously just with observation. But hyphema on day 1 post-op, I think is due to blood refluxing through the system into the anterior chamber with early distension of the canal, especially if there is some mild hypotony for a brief period of time during and just after the procedure. And again, that was common for me. Happily, perforations don't decrease the success of the procedure, and I think it's with microperforations that you'll have a more common or more significant short-lived hypotony. But this and hyphema both quickly resolve. I've also noted some cylinder early, likely due to the tensioning suture in a scenario of mild hypotony, but that also resolves very quickly. And really the comparison of these really early and short-lived, seemingly low-risk issues with canaloplasty to the well-known long-term morbidity for patients with TRAB really drives home the reality that the IOP-lowering success of traditional and penetrating glaucoma surgery has come at a large cost with regard to patient safety and satisfaction. And all of us, especially as we gain more and more experience, are really well aware of the disconnect between our definition of success and gaining a really low pressure and the patient's definition of success being based on a lack of this long-term morbidity. And that's really what compelled me also to recognize the validity of this procedure and follow the steps toward adopting it. I really regret that I didn't do it sooner, and I know Clay is amazed by how long I waited to try this. I sincerely believe that it's a compelling, much more sophisticated and effective IOP-lowering procedure, which will improve quality of life for us as clinicians and most importantly for our patients. If you're considering doing this, you need to, I guess it's the Nike logo that says just do it. That's what you ought to do. If you're considering this and on the fence, you should enlist the team and go through that learning curve and accomplish it. Thanks.